get to see, you get to diagnose, and you sometimes, in fact, we get to treat colorectal cancers just with the scope.
Super unfair. I mean, I felt it was unfair lah. I was the fittest guy and now I got IBD.
Yeah. So when we picked up cancers that could be sometimes even just 5 mm. Yeah, and they're just hidden within like a 1 cm polyp. Physical burden of the disease is so much more. Not just the physical, it's the emotional. If we can prevent it, nothing's more valuable than that.
Alright, ladies and gentlemen, we are here with Dr. Chong Choon Seng, colorectal surgeon.
Hi.
Welcome to our podcast where we talk about everything got to do with your colon.
Sounds good.
Sounds like a subject that you talk about every day, I guess.
Yeah, unfortunately, it's my line of work. Yeah.
Where's your practice at the moment?
It's at Mount Elizabeth Orchard. Yeah, so it's just at a hospital just across the road here from here. Yeah. Yeah.
And what's your daily life like, work-wise?
Well, it's a balance between doing ward rounds, seeing patients in the clinic, and then after that we have endoscopy, then we have surgeries. So not every day is the same, which is the good part about my life. But then again, it can get really hectic when you have to be like at 4 places at one time.
Yeah.
Yeah.
And I will also assume that your patients kind of need you
Well,
anytime. Like
Okay.
holidays are, you can't go for like 2 weeks holiday.
yeah, I think you do have periods of time where you could still take a break because most of the time we have scheduled surgeries. So then, and you know, like sometimes for Chinese, especially in the Lunar New Year period, they don't like to get procedures done. So we take breaks during those times.
Yeah.
So then that's where we get our offs.
Yeah.
Not much.
Yeah.
It seems quite miserable, but
then again, you also
something.
can't travel like Japan and go skiing.
Can. Actually, I went skiing last year in March. Yeah.
Which is also a good excuse, lah. Then you don't have to give ang pao, right?
Yeah. Okay. Shh, don't tell people that. Yeah. But I'm quite generous with my ang pao still.
Ooh.
Come and 拜年.
Dr.
Where's
Chong.
your gum? Where's your gum?
Dr. Chong,
Yes,
新年快乐，恭喜发财。
Okay, 好，红包拿来 after the podcast.
So why choose? I'm pretty sure when you first became a doctor, you had the option lah to choose whether you wanted to be a colorectal surgeon, brain surgeon, lung surgeon.
Yeah.
Why colorectal?
Actually, I think the thing that really makes me feel excited about is treating colorectal cancers. So cancer work is challenging, but at the same time, really rewarding because you treat a person with cancer. That's kind of like something major. And in Singapore, well, even in my time, colorectal cancer is the most common cancer amongst males.
Yeah.
And across for females, it's still the second most
Yes.
common. Of course, recently statistics are slightly different.
Yeah. Second after breast cancer.
Now, so for female, it's second after breast cancer, and male is second after prostate cancer. Yeah.
For
So-
male, number 1 is prostate cancer now.
Yeah, and from the last statistics that came from 2021 that concluded, but overall, it's still pretty much the number 1 cancer.
And is this
in
stats Singapore alone or international?
This is Singapore alone. Yeah,
Okay,
Yeah.
okay.
But most countries, you do see that colorectal cancer is definitely amongst the top 3.
Yeah.
Yeah. So it's still pretty common, and so because of that, I think I chose colorectal cancer. I mean, I chose colorectal as a specialty because I get to treat these people. The other thing is I really love to do endoscopy. I know it's just a little stick.
Yeah.
It's flexible.
Yeah.
It's nothing shady about it, but it
No,
does
it's
go.
everything shady about
Yeah,
it.
it does go to the place where there's no sunshine.
Where the sun don't shine.
Exactly.
And that excites you.
Well, it's just it was pretty relaxing to be able to you get to see, you get to diagnose, and you sometimes, in fact, we get to treat colorectal cancers just with the scope if it's early enough. Yeah.
I mean, with your removal lah. of
Yeah.
your polyps.
So just by putting a tube through the person's natural orifice, and if you find that the tumor or the growth is movable and relatively, I would say, not fixed from the rest of the intestine, you could actually inject and raise the tumor up, and you could just remove it, and you pull the thing out through the back passage, and that's it. So we do have a couple of those successful cases. It's not common. They form pretty much less than 2 to 3% of the entire population, where you see most of the time, by the time they come to cancer, they're like stage 2 and 3. But when you get those few, you feel awfully rewarding, right? Because that's it. That's the end of the cancer treatment just by doing a scope. Yeah.
What is colon cancer?
Okay, so basically, cancer is like an uncontrolled growth, and it can happen any part of your body. Like you said, you could have lung surgery, you could have brain surgery, and all. So the colon is essentially your large intestine. So if you have a cancer that derives from your colon, that's a colon cancer. And most of the time, it happens somewhere on the left side of the colon. You know, the colon is divided into the right, the left, and then the rectum.
Oh, I thought it was just large intestine, small intestine, and rectum.
So small intestine is before the colon. So so small intestine cancers are awfully rare. So when we talk about colon cancer, we really refer just to the large intestine, which comes from your right side, then go across abdomen, and it goes down to the left side, and then becomes a rectum before it goes to the back passage.
I hear you.
Yeah.
So in short, if I go backwards, it would be from this way,
anus,
it comes,
right,
it twists
left
up
side.
this way, and then it goes this way.
Yeah,
and then that's
down
the
to
end.
down to the
Also
right
go
side.
down.
Yeah, that's it.
And that's
Correct.
it.
Yeah,
Oh, like that.
like almost like a box.
Question mark.
Well, yeah.
Ah.
Very good.
Yeah, that's how we should put it.
Yeah, well done. And so colon cancer basically is cancer that arises from your colon, your large intestine, and usually arises from the left side. Yeah.
Colon cancer starts from this side, you're saying, most of the time.
I'm saying that it can arise from either the right part of the colon on the right side, which is called the cecum or the ascending colon, or
Yeah.
it can come from the sigmoid or the rectum. And this just refers to different anatomical parts of the large intestine.
You come from anywhere, lah.
Well, yeah, of the large intestine, but mostly, actually, it happens mostly on the left side.
Okay.
Yeah.
Okay.
Don't ask me the reason why.
I was just about to ask you. There's no studies on that.
Well, there are some biological differences between the left and the right, but in general, it happens more in the left, perhaps because of bacterial over proliferation more in that space, and perhaps also because that space is also where your feces stays more or less like the longest time. So maybe that's why it comes more often on that side. But there's no real biological proof that that's true. Yeah.
Okay, one day you'll find out. You'll let us know.
Or maybe you.
You know, when you've got other illnesses, for example, you got a fever.
Yeah.
It's easy to see. It's easy to detect.
Yeah,
I think
okay.
one thing that a lot of people don't know, that colon cancer, usually when you find out, is almost too late. Yes, no, true, not true.
Yeah, I mean, early cancers have virtually no symptoms, right? So I think that's the answer. So
Early cancers for all cancer, or
well, I think in general that's true.
yeah,
Yeah, but especially in the colon, because you need the colon growth to be of a certain size to have resulted in symptoms. And these symptoms could be like bleeding from the back passage. It could be like you have difficulty in passing motion, so you're constipated.
Yeah.
Or it actually leads to some kind of perforation, which means like a hole in the intestine.
Yep.
And that gives you abdominal pain. Usually by those times it's too advanced.
everything that you've mentioned is really super serious.
Yeah. So that's why you could imagine that when you have an early colon cancer, it's kind of small, the growth. It's probably not going to give you significant bleeding or pain or even kind of obstruction, because you need a growth to be big enough to obstruct your large intestine.
Yeah. Because when it's like a mole size, it causes no problem.
Yeah. So when we picked up cancers that could be sometimes even just 5 mm. Yeah, and they're just hidden within like a 1 cm polyp. So if you compare that to the diameter of your large intestine, which easily is like 4 to 5 cm, that's going to mean nothing. Right?
Yeah,
That's
you
gonna
won't
mean
feel
nothing.
anything basically.
Nothing at all.
Okay.
Exactly. Yeah.
So some common symptoms.
Yeah. So
Is everything you said? Which
well,
is
yeah, we
all
divided.
the bleeding and all the.
Yeah, essentially it is. So we divide into like left side cancer symptoms and right side, because left side symptoms tend to give you more change in bowel habits. Like your stool caliber starts to become smaller, like you start to have problems with constipation, and sometimes they can feel this thing called incomplete emptying. Whereas right side symptoms tend to present with more like anemia, which is a condition where you have low blood count, and that's because they lose blood through the feces, but it's not really what we call ovate, so you don't see it with your eyes.
Yeah.
And they also present with things like loss of
How do you
weight.
not see it? It's red.
Okay, so the red ones that people often are like worried about,
Yeah.
like you get stools in the blood.
Yeah.
Thankfully, most of the times it's not due to cancer, it's due to like hemorrhoids, which
Yeah,
is
yeah,
piles,
yeah.
right? Or it could be due to like a fissure, which is like a tear in the anus.
Yeah.
And if it's really bleeding from the right side of the colon,
Yeah.
the blood actually gets mixed in your stools, and they are a little bit darker,
Yep.
so they're not so obvious. So that's
Yep.
why they present more of occult blood
Yeah.
in your stool feces.
Yeah.
Yeah. And so in those cases, that's why we have this occult feces test, where you put a stick in your stools to look at presence of RBCs, red blood cells, and that your eyes cannot see.
Okay.
Yeah.
It's not a common practice we do at home, lah.
Okay, so
Take
you
a pasta
usually,
stick and then poke inside.
yeah, your pasta stick must be
Al
specially
dente.
made. Yeah, it must be specially made, and it has to be sent to a lab.
Yeah.
However, you'll be surprised to know actually this kind of stool test are provided for free, and in fact by pharmacies and by health promotion board, and
Yep.
people can take that test kit home.
Yep.
And once they go to the toilet, have their bowel movement,
Yep.
they can then use the kit at home and then send it out.
But not everyone, right? You have to have some like you
So
go
there-
to the doctor already, say I got stomach pain, then I want to check.
Well, then you should tune in for the coming month of Colorectal Cancer Awareness Month in March. Usually they run campaigns that allow for free distributions of such kits, but you must be 50 and above. So that means you are within the criteria for stool testing, for screening.
Yep.
And
Yep.
it's free. And as long as you provide your IC, you prove your identity, you get it for free.
Yeah.
Yeah.
But it's only the stool test, lah, not a scope free, lah.
No, unfortunately, no.
Okay,
But the
okay,
stool test is better than nothing.
Yeah, for sure, it's better than
Yeah,
nothing.
yeah.
But how accurate is that stool test?
Well, actually, the documented accuracy is somewhere around 70, sometimes even 80%. But yes, we have people with stool test that is normal, that have still cancer, and you have stool test that's positive that turns out to be not cancer as well.
Yeah, you're saying roughly a rough number,
roughly-
70%.
roughly
Then
accuracy,
what?
yeah.
What about scope? A scope is 100%.
Well, nothing's really ever
Nothing's
100% in
sure.
medicine, unfortunately, but it's close to like 98%,
Okay.
where you're going to pick up all of your cancers. You might miss very small polyps,
Yeah.
or you might even sometimes misdiagnose a cancer. That means it looks like cancer, but once
Yeah.
you take it out, actually it's not a cancer.
Yep. Benign cancer.
Sometimes
No.
it's just infection or inflammation.
Oh, okay,
They can look like a growth,
Yep.
but actually it turns out to be just due to inflammation or infection.
Got
Yeah.
it.
Yeah.
Hey, look who we have here.
Ah.
Mr. Don
Hey, hi.
in the house.
恭喜发财.
Yeah. Is it
I
it
thought
Chinese?
you are
New
giving me.
Year? Hey, come join us. Join us. Grab a chair. Wow. Okay, come grab a seat. I'm sure you of all people will definitely have a lot of questions.
Okay, Dr. Chong. So
Yeah, hi.
actually, I had my scope done last week.
That's good.
Yeah, polyps,
Okay.
chronic gastritis since a young age. You know,
Okay, that's
working
from the
too hard,
stomach. Oh.
skipping my meals,
Mm.
the Singapore struggle. Yeah, but you know, now at least I have a peace of mind.
Yeah,
So,
yeah.
just a few questions for people tuning in. Like, how do these symptoms typically manifest, and at which point should one seek medical treatment?
As in symptoms pertaining to the polyps and the
Oh.
gastritis, the ones that you
Yeah.
mentioned? Okay. So just to be clear, gastritis is basically inflammation of the stomach,
Okay.
right? So that one, yes, you can have symptoms like tummy bloatedness. You may feel a little bit of pain if you miss a meal. And sometimes you might even feel that your tummy is a bit bloated, like a bit bigger than usual. So that can be a common symptom that people have. Whereas for polyps, it's referring to growth within your colon. You can have polyps in the stomach, but those are generally not cancerous and not to worry about.
But polyps are generally not cancerous?
Okay, so polyps in the stomach and polyps in the large intestine, I'll treat them separately. So polyps in the stomach are really not cancerous, but they are not even precancerous. Very, very seldom when we see stomach cancer, it's arising from a polyp. The opposite is true for the colon. Polyps in the colon generally are still benign, but they can be precancerous. So if you don't remove them over time, they can become cancer. And most cancers in the colon arise from polyps. So for polyps in the colon, they don't have any symptoms most of the time, none at all. So that's why it's good that you went for your scope, because like you said, once you've done it and if you've checked it, you removed it, then technically you don't have a risk of getting colon cancer at least for the
I
next
think
3 to 5 years.
what I got was essentially a peace of mind.
Yes.
But why do you randomly just go
No.
do your scope?
I mean, I think I mentioned in the first episode, right? I had my first scope when I was 27.
Oh,
I had this super pain,
yeah.
tummy ache.
Mm.
I couldn't like stand straight without feeling the pain. I was like crouching and all. So like, I mean, I did my first scope at Mount Alvernia.
Yeah, yeah.
And
yeah.
I think I was supposed to do one.
Yeah,
And then
yeah.
finally
Yeah.
had the chance to do it last
And
week.
you had polyp that time as well?
Yes.
Okay.
At
yeah.
27.
Yeah.
I don't know. It's
Yeah.
quite young.
Yeah,
Am I right?
it is. You're
Am I
right.
right?
So indeed, if you have unexplained abdominal pain, you should get an endoscopy as well. But of course, case to case basis. 27 is pretty young, and sometimes if your symptoms do go away with medical treatment, you might not do it. But since it was done and you had a polyp, then it is advisable that you still get another surveillance down the line. So if you got one repeated last week and it shows that you have polyp and now it's removed, then you're good for usually another 5 years, right?
So you're saying as soon as you detect like polyps, then every 5 years?
Yeah, so we do have some guidelines about that. It also depends on the size of the polyp, the number of polyps you have, the type of polyps you have. So without going into details, it's almost like a matrix that the higher the number of risk factors you have, then the closer the interval. So you might get one in 3 years, but rarely do you need a yearly scope. Yearly endoscopies is really left for people with very high risk for cancers, like patients with what we call familiar or genetic colon cancers. The conditions, the names are like familiar adenomatous polyposis, or HNPC syndrome, which is also known as Lynch syndrome, or people who have inflammatory bowel disease, where the conditions known as ulcerative colitis or Crohn's disease.
Yeah, which is what I have. You see.
Oh, okay. Sorry to hear that.
Yeah,
but
unfortunately.
But if you have it, well, then again, it's not. So you don't always have to get a yearly scope, especially in the first 7 years of your disease, unless on the very first scope you detected, you already have polyps.
When they first detected there were polyps, they removed it and it was benign.
Clean. And after that, is the rest of the colon clean?
Yeah, I first got it about 7 years ago. I'm 37
okay.
now. So I first got it when I was 30. IBD, UC.
Yeah.
So eventually I have been going every year for scopes.
Okay,
Only on the
yeah.
first year they found polyps, removed it, benign. Ever since, no.
Yeah. So
no
after
more.
7 to 8 years of active disease, it's true that now you're in either 1 to 2 yearly scopes. Again, depending on what's the appearance in the scope. Because if you imagine, since cancer, most of them comes from polyps. If your scope, you have many, many polyps on your colon due to the inflammation, then you will need yearly one to see which one becomes cancer. And hopefully an earlier detection means you get earlier treatment.
Yep.
But if your scope is mainly just inflammation, may not be polyps, may just be some ulcers, then you may not need always a yearly scope. Maybe, especially if the activity is well treated by medications, then sometimes you can do it maybe 2 years. I mean, all this is a balance. It's a case-to-case discussion to try to balance the morbidity versus the chance of getting a cancer between the next scope. Yeah.
Yeah, what kind of a demographic of Singaporeans or maybe people around the world get colon cancer? You know, do older people get? Does age matter? Does gender matter?
Nationality?
What you
Okay.
consume?
Asian,
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 yeah,
European,
yeah.
African. Like, is it true that Asian man has the highest?
Okay.
Is it true that Asian man has the highest
Yeah,
rate?
yeah. So if you look at maybe let's start from the simplest one. If you talk about age, indeed age is the predominant factor for colorectal cancer. The older you are, the higher the risk, and it seems as though that 50 is the magic number, but that number has been challenged, right? 45 for America, and in fact coming lower and lower, and in fact this is all age for screening. It doesn't mean that before the age of 45 you don't get cancer. And we do see patients who are 30. I have patients who are as young as 18 years old who has colon cancer, and they don't even have family history. 18, 1-8. Yeah.
Wait, it's interesting that you said that they don't even have
Family history.
Family history, meaning
Yeah.
you're saying that
Meaning-
family history plays a part.
Yeah. So for those patients with familiar or genetic colorectal cancer, like the two conditions I mentioned, FAP, familial adenomatous polyposis, or Lynch syndrome. So imagine your dad has that mutation in the gene, you could pass it to your next generation. So then if you have it, then you are more likely to get a very young onset cancer. And usually for those patients, they get it like when they are 20 plus, towards the end of 30 years old.
Shouldn't everybody go for that? How do you even detect that? Do you do blood tests for that?
Okay, it is both a blood test, it can also be a tissue test, but generally we don't need to check everybody for it because it still accounts for only 1 to 2% of all patients with colorectal cancer. And hence, if any person who has a family history where their colon cancer onset is very young, like less than 40 years old, that index person gets a test for the genetic mutation. And then after that, if he has the mutation,
He should never have kids again.
no. that one, Prime Minister will come after you. No, so basically what it means that if he has that index gene, then he will go through what we call genetic counseling, and he will then get relatives who may inherit that gene to go for the same kind of counseling before they decide on whether you want to check for that gene. Because there's a lot of implication in knowing.
Counseling? What counseling are you referring to?
Well, it means that you need to know if I do this test on you and if it turns out positive, it might not just affect you, but your decisions in life, like getting married,
Yeah.
getting a job, getting
Yeah.
insurance,
Oh.
right? You see, these are all the downstream so-called implications about doing a gene testing. So it's not as if it's like, oh, just do it lah. It's better to know than never, but the implications have to be advised upon.
So before checking anything, you should always buy all your insurance.
I don't think we sell insurance today, right? Yeah. This one, please refer to your respective insurance agents.
But I'm sure you've seen like a lot of people come into your office and then after you've diagnosed them, then they kind of can't buy anything.
Yeah, well, I think insurance covers a lot more than just cancers lah. It's also all about your liabilities and how you don't want you don't want to become a burden for your family or the loved ones. So I think insurance is important personally. Yeah.
Yeah.
Jeanette.
Yeah, so coming back is that all the demographics, right? So we mentioned about age, we mentioned about people with strong family history of cancer. So those are the demographics. If we talk about population or so-called Caucasians versus Asians and all, well, in general, it's actually between both. It's about the same, So it's not an Asian predominant disease. But if you talk about gender, then males definitely higher than female.
Really? Why males more than females? Just genetics.
That one ask God lah. That one.
Ask
Yeah.
God. Okay, I thought maybe it's because the food we eat or the testosterons.
Okay, I think we're not going there anymore. Well, the truth is that there's no real biological reason for it, but males do get a higher.
Just statistics.
Yeah, it is.
Okay.
It is. Yeah.
So it's interesting when I had my IBD,
Yes.
I was 30.
Yeah.
I was the fittest guy. OCS, I was
Wow.
best PT. I was running
Wow.
825.
Wow.
I was doing track and field
Wow.
for school all my life. Primary school, secondary school, poly, uni. I was basically the fittest guy. And one fine day I just started going to the toilet 20 times a day.
Oh, just
a day.
suddenly, just like this.
Just like that.
Wow.
And I went to see a doctor. Doctor said, come, charcoal pill, take it.
Oh, yeah.
One more day, still, then blood started coming out. Went to see another doctor, said, go hospital
Yeah.
now, what are you waiting for?
Yeah, bloody diarrhea.
Yeah, then check, IBD. So I always feel like, wow,
Unfair,
this, yeah, it's super unfair. I mean, I
Yeah.
felt it was unfair lah. I was the
know.
fittest guy and now I got IBD.
Yeah.
You know, does all this sports and working out kind of help or not help
Yeah. Okay, that's
colon cancer?
well, to be honest, it actually does help. It actually does help. So, based on population-based studies, if you look at whether it's daily activity or between populations who are naturally exposed to a high level exercise or physical activity versus those that don't, it is consistently shown that physical activity and exercise, and we're talking about regular exercise, is a protective factor towards cancer. Reasons are manifold. We know that increases, first of all, your immunity. And if you have good immunity, you detect abnormal cells that develop in your body, including cancer cells, then you will naturally rid of yourself of all these cancer cells. The second thing about physical activity is it reduces weight, and obesity is also a risk factor for cancer.
Oh, obesity.
Exactly. So if you have increased physical activity, you have less obesity, and then you have less predisposed towards cancer. Yeah. There are many good things about physical activity, but unfortunately, like you mentioned, there are still people who are the fittest person around. They don't smoke, they don't drink. They ask the why question, which is very difficult to answer from a doctor to a patient perspective. It is unfortunate, but yes, in such cases, then genetics plays a part. In fact, IBD, inflammatory bowel disease, is a genetically predisposed condition. There is somewhat genes that we identify, something like HLA-B27. Basically, they have mutated, and that you have receptor changes, and that's why you produce antibodies towards your own cells, resulting in that inflammation.
So then, would my kids have it?
Yes, there is an increased chance of passing on to your kids.
Not guaranteed.
Not guaranteed, because unlike the earlier condition that we mentioned, like FAP, where it is like a single gene that is predominant with a mutation, and when you pass it down, it has a dominant fashion, which means 50% chance of inheritance. This one is more polymorphic, which means that there are multiple genes that are so-called responsible for the trait that you have. So you may not pass all of them down, or you may pass them in several patterns that may not exhibit the same kind of physical trait, that means the condition in your progeny, basically. Yeah.
I just want to check. You mentioned drinking.
Yeah.
So like late night partying,
Yeah.
alcohol.
Yeah.
Does all this increase your risk?
Yeah.
I mean, I don't drink, you know.
Yeah.
There's always a Singapore thing that says, hey, you drink alcohol, you wash all the toxins out.
Oh, wow, really?
No.
Well, first of all, I must clarify that I didn't mention drinking. I think it was always in your mind. But the truth is, it is a risk factor for cancer. But the evidence is not as strong as compared to other factors like smoking. Yeah, smoking is one of the highest independent covariates for cancer, meaning that it is something that's completely modifiable, and it has like a very significant increased risk ratio of cancer versus if you're a non-smoker. But alcohol, yes, it is. For colon cancer, maybe less. But certainly for things like stomach cancer, liver cancers, it's higher.
I mentioned this because I think a couple of months back, I just went out, had a couple of gin tonic,
Okay.
a lot of acid in it.
Mm-hmm.
Went home, wasn't drunk. My stomach was like burning.
Yeah.
It's just like gin tonic. It's like you can't get drunk from gin tonic.
Are you worrying that you got colon cancer?
No, which is why I went for my scope, to be honest. It was really pain. I was like, it's like, oh.
Because you're gin and tonic.
Yes,
Yeah.
no, I just like,
Yeah, maybe we should set up an endoscopy next to all bars. Yeah. Okay, but remember that you shared that you had this thing called chronic gastritis.
Yes.
So that
This
is
helped.
probably the reason why you had it, because of alcohol, and it also exacerbates the attacks.
so life sucks. I can't drink gin tonic.
No, life is good. Just don't have too much of it.
No, I
Yeah.
Don't be
I-
too paranoid.
I don't
Yeah,
drink
yeah.
anyway.
Yeah.
So just 1 or 2 cup can make me in such
Yeah.
pain. So like quite fearful now.
Yeah, I mean, sometimes that's the way I see it, is that is your body telling you that you should take care of it. Maybe you think that you didn't have too much, but it's obviously too much for you to take. So then what you should do is that have everything in moderation, take care of your body first, help with your other factors like your stress, your lack of sleep, and when you're better, then you can probably stomach a little bit more.
Okay.
Yeah.
Can what you eat prevent or cause cancer?
Yeah, again, a very common question. And we know that there are certain diets that predisposes you to a high risk of cancer, but it's never a direct link. So such diets like,
McDonald's.
well, saturated in fat,
Mala,
yes.
mala.
Okay, spicy, not really. Okay, so I think if we mention brands, I think this podcast is gonna be like, you know, yeah. So we're talking about again food types, So saturated in fat. What other food types? If you have low fiber diet, if you have diet that is very high in sugars.
Old guy holding
Sorry,
chicken.
why low fiber diet?
Well, again, it's just based on these are like population health studies. So you take a sample of like maybe say a few hundreds or even thousands of patients. You ask what they eat, and you look at the actual number of people who get cancer in those who eat more and those who eat less.
I better worry because I really eat a lot of fast food and I don't eat vegetables.
Yeah. Okay, so you should, especially for IBD, you will know that organic kind of food seems to fare better with you. So we're looking at things that are more natural stuff, less preservatives.
Meat
So-
also organic, what?
Sure, but if you don't take vegetables, then your chance of being exposed to organic type of food is less. Because vegetables and all this provides all your minerals and your your vitamins, and amongst them you have all your antioxidants, and you have things that actually modify the way that you respond to immune or stresses. So it's very likely that you're losing out on some of these critical minerals and vitamins. So as now for cancer, so if you have low in fiber, again it might be the fact that you're losing out on the same type of elements, but it may also be the fact that people who tend to take fiber or are fiber conscious take a conscious I would say guide towards their health.
Yeah.
So
Do a bit
then-
more exercise. And all that.
So therein lies what we call this confounding factor. So that's why when you ask about diet, right, you can be eating the best of things, but if you
Start
also
smoking. And all
yeah,
that,
very very good, exactly.
Yeah.
And you start smoking, you don't take care of your health, then I think it's going to wash out all that effect. Because smoking is the number one really bad, I would say, independent co-variable for cancer factor. So you should start with those first.
Oh yeah, speaking of which, what is your hierarchy like for the cause of course you won't know what's the cause for that particular patient's cancer or that particular patient's cancer, but
Yeah.
but from your demographic of
Mm.
people that you've seen, what is the highest cause of cancer? Your
Okay.
guess, your best guess for their cancer?
Yeah, okay. So, actually, if you talk about the best or the highest risk factor, in so to speak, it has to be age, unfortunately.
Age.
Yeah, because you can really just like throw a stone amongst a group of, I would say 50 and below, versus you throw a stone amongst a group of 70 and above. You're going to be very much likely hit a person with cancer in the older age group, and in the earlier one, you might throw that 100 times and you might not get one.
You said cancer, but you mean colon cancer.
Well, I would say that in this case it's colon cancer, because not all cancers happen in that way. Like and the classical example of that would be like blood-borne cancers. There's certain types of blood-borne cancers happen more in the young.
What's this blood-borne cancer?
We're talking about leukemias.
Oh, my dad had leukemia. He passed.
I'm so
is
sorry.
that hereditary?
Okay, so if he's of the old age and a certain type, right? So there are different types of leukemia. There are really many subtypes, and then usually it's not.
I wish I could ask him what type his was.
I'm so sorry, but yeah, but okay. Generally, most of the heritable one leukemias, you would see them more in the younger group lah, in that sense. And again, we're coming back to colon cancer. We are saying that age is indeed the biggest factor for it. Then when it comes to the next one, it will be the thing that we mentioned, smoking. Yeah,
Really?
smoking.
Wow.
Right. Then if you have any other hierarchy after that, I would say then it's our Western lifestyle, which leads to obesity, because all that's kind of related.
Yep.
Yeah.
Obesity.
Yeah.
Not drinking.
Well, yeah, so that's
Gin
why
and tonic,
drinking is like somewhere
Gin
there,
tonic.
but it's I mean, drinking is really it's not consistent, but it has been shown that it's a risk factor, and again, it's somewhere there with your lifestyle modification. But if you have that 1 and 2, and then you come to drinking, I think that would be my
I mean,
my hierarchy.
if you tar the Mao Tai every day, you're asking for it as well.
Does
some-
it affect?
They-
Burning, literally burning. I mean, I'm just
Yeah.
saying, like, that's the thing. Like,
Yeah.
I always feel that, all this like alcohol, you are burning something inside. Are you
Well, it's acidic and it's caustic, right? But I think more importantly is that if you do that, you're going to kill all your other organs faster than your colon actually. Right? You take out your liver, your stomach. And
So I guess colon cancer. People who drink alcohol seldom get colon cancer because they die of other issues, other complications.
well, I don't know many people who drinks Mao Tai every day like this. Yeah, but it's true lah. Yeah, everything in moderation. Okay. Yeah.
I think everybody always kind of thinks that they don't have it. My mom specifically, she just will not go to the hospital. She will not be sedated, and she will not put any foreign objects up her body.
Okay.
All right. So begs the question, are there any other methods that people you would recommend, to get themselves checked?
Yeah, that's a good question. So, indeed, we do have people who are, well, not just hospital adverse, but they are very adverse towards having any procedures because of the risk or the discomfort. I think the disclaimer here is that number one is that most of these procedures are done with sedation, and it's not uncomfortable.
Yeah.
You've been through it yourself, you know. But if there's really alternatives to choose from colorectal cancer, you could do stool tests. That's one, and it's quite accurate. But we must know that if the stool test turns out to be positive, she still has to go for the scope. Which why begs the question that actually the scope itself is the most accurate and probably the preferred test.
Yeah, but at least, like people like my mom, they will never go. They will never go. But I mean, unless
Better than nothing.
But unless you tell them like, hey, look, just do this stool test and we'll see. And when the stool test shows them positive, then they will go.
Yeah, possibly. Exactly. Yeah. The only other alternative is like we call it scan, like a CT scan or computer tomography, and you use that to look at the intestine. But again, very much like the stool test, if you find something positive, you will still need the scope to get tissue for confirmation. Which is why you find that between all said and done, you need to do a CT scan in a hospital anyway. You can't do it in polyclinics. Yeah. You need preparation anyway, same as a scope. That's why colonoscopy is the gold standard, and then stool test if you don't want colonoscopy for whatever.
Yeah, less invasive.
Yes,
but how much is like the stool test? For people like my mom.
We just mentioned it could be free.
Could be free?
Yeah, you could really get it from like polyclinics, pharmacies, especially during the month of March.
Why month of March?
So every March it's a colorectal cancer awareness month. So that's where there is all this nationwide campaign. This in Singapore is championed by Health Promotion Board, and they actually provide these kits for free, and it's distributed to the population when they go around to ask for it. And I will encourage anybody who has never done a test before and doesn't want to get a scope.
So what do you have to do? You just show up on the day itself and.
So if you don't know where to go, again, there will definitely be news, there will definitely be like media broadcasts and things like that, and they could tell you where to go. But from previous years, what they've done is that they assign it to like polyclinics, some GPs, and also they also assign it to like even Guardian pharmacies.
Not everyone can get it, right? You have to, there's some
50
requirements.
and above.
50 and above.
Yeah.
50 and above.
So you go there, you say they're interested, you give your IC, and you just get a kit home.
Free of charge.
Yes, free of charge.
Huh.
Yeah,
Wow.
yeah. And I wouldn't be surprised even if you go to the major hospitals, when they run the campaign, they might even distribute the kits.
But all government hospital.
All government hospitals. Private, I'm not so sure, but all government hospitals definitely have. Yeah.
Okay, I'll grab one for my mom. March is coming.
Nice, yeah. It's just around the corner. Free.
She just did her scope last year.
She just did her scope last year.
Yeah.
Oh yeah, so she did her scope last year. Should she be checking?
So she did turn out for endoscopy.
She did. Yeah.
Congrats, nice.
It's so strange because I personally, you've done your scope super early. You did at 27. I did at 30. I know it's not competition, but a lot of people don't know when to go.
Yeah.
Like what's the guidelines?
Yeah. So indeed, we have our own Singapore guidelines, and we have also like international guidelines. So in Singapore guidelines, we haven't changed. It's still 50 and above, and we're talking for patients who have no symptoms. So we call them asymptomatic individuals. So, but in America, it's like 45 and above. There's lots of controversies going around, like why did they do that, and is that justified? It is based on the fact that we are seeing an increased number of colorectal cancers in the patient population between 40 and 50, even in Singapore, if you look at the national census. However, it still remains the minority. That means compared to the larger cohort of colorectal cancer patients, they are generally all the 50 years old and above.
When you said 50 and above, how many, what's the numbers like? Like out of 100 people that are 50 and above, how many people get colon cancer?
Yeah, so if you look at, I think above 50 years old, they further segregate into like something like 65 and above. So it's like 50 to 65 and then 65. So between 50 and 65, you're looking at something like 1 or 2 in hundreds. Something
That's a lot still.
Hundreds, okay?
That's a lot.
Yeah.
But you see the
So did
drastic...
you say hundreds or 100?
Hundreds.
Oh, okay.
So but you're looking at... But you see how the scale decreases. It's quite scary. So when it comes to less than 50, it's like 1 or 2 in tens of thousands. Versus 1 or 2
So you
in
see
hundreds.
the magnifying effect.
Then when you go to 65 and above, you go to like 1 or 2 in like hundreds. That means less than 100. That means 100 and less.
100 you'll get
1 or 2.
Oh, that's a lot.
Yeah. So it's like the magnitude really
drops.
changes a lot. Yeah. And of course these are what we call population based estimates. So they have you have census data and you just divide about the total number of patients alive and per year kind of thing. So it's not exactly like, okay, you check like 100 people, you definitely get 1 or 2. But for every 100 year that a 65-year-old and above is living, you might just get 1 new cancer diagnosis. So it's actually quite a lot. But most of the times, if you look at the data again, the cancer incidence is dropping, and the biggest drop is indeed the older age group, because we are screening earlier and earlier, which is really good, because so you see all that downstream effect when you start screening early. So at 50 years old, if you check them, you found the polyps, you remove the polyps. By the time they go into 10 years later, 60 plus years old, you check them again, they're just polyps, they don't have cancer. So that's why the sharp drop really comes in the older age group.
Yeah.
And that's why there's that impetus to start to move the screening earlier as well, because now then you have that 50 to 65 years old that you want to see that same effect. You want to mirror that effect of coming down. So then people do come and ask, can I get a scope done? We don't actively reject them, but again, we will risk profile them and we have to talk to them, again, based on what is the benefit versus the risk. Because if I have a patient who is like less than 40 years old, say something like 35, he might even have some symptoms, but the symptoms are like hemorrhoids, like piles, like bleeding.
Are you not allowed to scope them?
No, there's no not allowed, but it's whether it's really medically indicated. So you just need to examine the patient, and if indeed it is just from the piles, he could be very well just treated with medication for piles, and his symptoms goes away. Then you don't really need to spend the extra money, time, and also the effort to prepare your bowel, to come to hospital.
All the bowel prep.
All the downtime from work.
Yeah.
It's probably not needed, right? But however, if the symptoms persist or he has other kind of symptoms, then of course, sure, go ahead.
So are you then saying that people who are like 45 years old, no symptoms,
You should get 1 scope according to the American guidelines.
Oh, by Singapore.
Yeah, so that's why there's always debate, because evidence and practice can sometimes there's a lag, because you observe all these trends from like 5-10 years ago. So do you change it now? Do you wait for the future, or you wait for more data? I mean, it's guidelines are guidelines. They're not prescriptive. So generally you look at the patient, and I do have patients who are maybe even 42, 43, but a grandfather got cancer, grandmother, uncle also got cancer. They are relatively distant relatives, but they all had cancer. So would you not check them? I would say that probably you should get 1 check, especially if the patient has some symptoms.
Yeah, so I guess for me now is because I'm doing podcasts like that. I don't want to be going out to random people on the street, like a random friend, and say, "Hey, how are you? You're 32? Oh, nice to meet you. Anyways, have you done your colonoscope? You know, because he's got no symptoms.
Yeah.
But I can go to someone who is 52 and say, hey, hi uncle, nice to meet you. Anyways, have you done your colonoscope? Haven't. You should go.
Yeah.
See the stark difference?
Yeah.
So then again, when should I be telling people, you know, having the conversation with people, like 50 and above lah?
Yeah, I mean, generally, I don't think that anything from a podcast has any medical, so-called legal implications, that whether you're giving the right advice. So I think if you put 50, I think that would be a very safe local guidelines. You're probably definitely in line with what the evidence would suggest. But if you're looking at anything that's less than 45, I would say then that's probably not really needed, right? And I'll then leave that 45 to 50 as a gray zone. You could then, I would say if I'm the podcaster, I'll be like 50 and above, you should get one. Less than 45, well, if you have any symptoms, see a doctor. And then 45 to 50, you're like, you should consider one.
Yeah.
So that's what I would say.
It's hilarious because earlier on, just outside, I met this girl, and then how old is that lady we just met from the chiropractor? 1990. So she's
Chun, 44.
no, like okay, 3 years younger than me. 3 years younger than me. Only 30.
39.
No, I'm 37, so she's only 34.
She's 34.
She's
34.
this only 34.
34.
So I was like, hey, have you done your colonoscopy? I said, no. I said, I think you should. So it's totally off. Like I should only be asking people.
Well,
okay,
that's why you're a podcaster.
yeah, I'm
which is
learning.
good.
I'm learning,
Which
right?
is good, yeah.
Yeah. So basically, if a lady who's in her 34, 35s and she's having some symptoms of,
See a doctor.
see a doctor.
Yeah.
See a
Because
doctor.
I mean, we have only been talking mainly about cancers. You see. I mean, where you asked the other lady friend that you talk about, it's because you had your personal history of inflammatory bowel disease, which is an uncommon, but still it can be a disease that afflicts the younger age group.
Yeah.
And we do scope patients like that as well.
Yeah. Like
So-
you said, as young as 18 years old.
Yeah, can you imagine if we say it's a hard fixed rule that we never scope patients less than 40, then you'll never pick up all these patients.
But if I may add, right?
Yeah.
So I think the guidelines for using your MediSafe to scope in
In the screening context?
in a screening context, right? Is 50.
It is. In
It is
Singapore.
50.
Yeah.
Like it's
Cast in stone.
cast in stone is 50. You have no conditions, asymptomatic. You walk in, screening colonoscopy, MediSafe.
Oh, yeah?
That's 50 and above.
Exactly. Yeah.
Under 50, example, my issues.
Yeah.
And mine.
Example, like really
Yeah.
bad
Yeah.
stomach ache. I
Yeah.
couldn't stand straight.
Yep.
Like affecting my sleep.
Yep,
Even
yep.
though I'm 36, I just turned 36.
Yeah.
Then I saw the doctor.
Yeah.
Of course, I'm really worried. I want to know what happened. So the only way to see what happened is,
Yeah.
I mean, if I have history as well.
Yeah,
Because
yeah.
I had my first scope done at 27. So
Yeah.
even though I'm young, it was recommended.
Yeah.
It's called diagnostic
Yep.
diagnostic
Exactly.
colonoscopy.
Yeah.
So
Correct.
for the healthy people with no symptoms above 50, it's called screening colonoscopy.
Yeah.
So
Yeah.
screening colonoscopy.
Yeah.
For people like me and him,
It's diagnostic colonoscopy.
we are under 50, young, not so eligible, but yeah, it's called
Diagnostic.
colonoscopy.
Yeah.
Okay,
Correct.
so I think it's just to let the public know the difference
Yeah.
in terms of the terminologies. Yeah, okay.
Yeah, you're right. So there is this difference. So that's why when you have a patient who has medically indicated issues for scope, then it's called diagnostic. So you can do the diagnostic colonoscopy above 50 as well. So I mean that means like for patients who had a scope done say at 52 years old, then at 54 years old he start to have severe abdominal pain, no explainable reasons, you can repeat the scope as well. So I mean, it is mainly based on the insurance claims and also MediSafe claims that there is this discernment that was made whether it's done for screening purposes or diagnostic purposes. But medically, if you ask me as a doctor, I'll be like, yeah, we only do it when it's really necessary.
Yep.
That means if it's a patient that is young, then you see whether the symptoms are going to resolve to medications. If not, then you get a scope. If it's for patients who is slightly older, you'll be like, okay, you're going to need a scope. Anyway, we'll still treat you with medications first, and we'll schedule for a scope upfront. Yeah.
Got it.
Yeah.
Then we are healthcare. Well, we are healthcare providers. Okay.
Technically, healthcare providers will be like, for example, nurses, doctors, pharmaceutical companies, people who are within any healthcare,
Yeah.
and they have to be the provision of healthcare. Lah.
Yep.
Yeah.
So is it healthcare providers' duty to do it? Because
Okay.
otherwise,
No lah.
I mean, they don't teach it at moral and civics.
No. Oh,
They
yeah.
don't teach it in school.
Yeah.
So how else are people gonna know about this? It's only through, like, I guess, podcasts or
Yeah, so I mean, generally you will find that most healthcare providers, like, they become, what do we call that? Maybe like champions of such knowledge. That means they become the go-to source. It's not unusual for any individual who has a relative or a friend who is a healthcare provider, and they always become the first avenue for information. Like, oh, hey, I have this. What happened? What should I
Yup,
do?
yup, yup.
Who should I look for? And
Yup.
things like that. So they become the first avenue of, like, information. But yes, on a larger scale, not on an individual scale, healthcare providers can also be part of, like public education forums, campaigns, like running like
Yeah.
cancer, colorectal awareness months,
Yup.
giving talks, public forum talks.
Yeah, but who's gonna fund all this though?
Actually, some of them are government fund, as well as other things are funded by, like, institution as well. Like most of I think even like Parkway or your public institutions, they will usually fund some of these public-facing forums. And you do get public, like, it's an open invite and it's free. They go to such seminars and all. They get information from them. I do think that Health Promotion Board also does a good job.
I'm sure.
Yeah, they usually put up like posters and all, and you do see commercials,
Yeah.
right? You see that they talk about, like,
Oh, that's true. That's true.
right,
Yeah.
health
Yeah.
screening stuff.
All the advertisements.
Yeah.
Then sometimes
yeah.
they just, like, put the setting of
Yeah,
who's-
quite emotional.
Yeah,
also.
Uncle Tan recently hospital.
Yeah.
Yeah, I think last week, I think they had a program on Channel 8. I think Li Guo Huang and a few of the others were talking about colorectal cancer.
Okay.
Yeah, it's quite shocking. I mean, quite mainstream now.
Yeah.
To see, like, primetime TV,
Yeah,
people
yeah.
sitting around like
Yeah.
us, talking about colorectal cancer.
Yeah.
So I guess in a way, what we're doing here is also to spread awareness. I mean, so if you're young, you come across this, it's just checking on your parents, your
Yeah,
aunties, your
yeah.
uncles. Hey, I came across this. It's basically just sharing of knowledge and just to spread awareness about colorectal cancer.
So your March is what? Colorectal
Cancer Awareness Month. Yeah.
Colorectal cancer awareness month is you've got your stool test.
Yes.
That's free.
Yeah.
But your
yeah.
scope is not free.
Yeah, unfortunately.
Then how do, like, the people who are less fortunate get it done?
Yeah, so indeed, most of these scope facilities will require some kind of facility fees, and there's doctor fees.
Yep.
And generally, patients who have insurance and MediSave,
Yep.
especially if you have insurance that covers for, like, shield plans, right? We call them the integrated shield plans, or you have those that covers for hospitalizations. They can all provide for the cost of the scope. I think that's the first.
I think to begin with, it's not very, very exorbitantly expensive.
Oh,
Because
yeah.
usually when people think of,
Yeah.
like, surgery, I need to go to the operating theatre. They imagine
Yeah.
like a limb and a leg, like 6
you're right.
digits.
Yeah, that's a good point.
Yeah.
So in fact, you usually just the costs are all published, in fact, in papers before. Like, if you look at screening scopes, they range from something like 1,008 to something like 2,000 plus. Even if in a private hospital or a private patient in a public hospital, it's usually about
About the same
2,000
price,
plus
yeah.
to 3,000. Yeah, so it's about the same price. So, but the key is that for the patients who, like you mentioned, the underprivileged patients, then they don't even have insurance, then what can they do? So
Yeah.
there are some volunteer groups out there. One of mentioned is actually the 365 Cancer Prevention Society. They're kind of like a group where they source for basically funding, and the funds do come from either organization. I think they may also come from some public crowdsource funding, where they then look for eligible patients. And I think there's also some kind of means testing done to make sure that they are from that class. And so that then they allow them to go through endoscopy, in this case a screening scope, and so that they don't have to pay a single cent. So then the fund is provided by such, I would say, the donors. but at the same time to make it feasible, because you don't want to end up getting like donations and you like use them and in the bills and all, right? So
Yeah.
what they have done is that they have worked with the Singapore Colorectal Society, which I'm part of, and that we have come to some kind of agreement that we will look for scope facilities, and these are scope facilities in private, like such as this center here, like Curasia,
Yep.
as well as different centers in Singapore, to lower facility fees as well as the professional fees, and then made it more affordable for them.
Yeah.
And in the whole entire
But it's like a crowdfunding.
yeah, so I think the actual source of funding actually comes from donations. So 365 Cancer Prevention Society is the anchor. And what we have done successfully is that for the last 2 years, we managed to get about 20 plus per year to about 30 a year to get scoped for free.
Okay.
Yeah,
But how
so-
do you even find these people?
Yeah, so they actually, I think, work with various channels of advertisements. I think some of them actually works through grassroots events. So they have like events in the community, and this is where your target population is, right? They usually stay in maybe a single room HDB, and they will then push out this information. Actually, the truth is, it's really a very warm feeling kind of event, because they probably never even had a chance to listen to such podcasts.
For sure.
They
If they
don't
even have a
have-
phone.
Yeah, they don't have all these avenues or revenues of information, and so that's why this society, they have to go out actively to look for them, tell them that it's free, tell them it's not a scam,
Yeah. That's the hardest part.
and to come and because they're probably very busy as well making a living, so they have to come for that 1 or 2 days, get the doctor to see them, eligible to be tested, and then another day for the scope to be done. And we have picked up some patients, not with cancers, but many polyps.
Yeah, I'm sure you have, because from all the
all the
lifestyle that you're saying,
stuff.
like the fatty food or your smoking and all that, I'm sure a lot of them,
And
unfortunately.
I never had a chance. They never had much choices in life.
Mm.
So I do applaud such efforts. I only mention this particular group because this is the one that we're working with, but I'm quite sure there are other volunteer groups out there who probably have the same agenda. And I would say that this is a very good call for the public, that if they think that they want to do something as a change to help the public health awareness and contribute actively towards their health, actually this is a very good way to, because prevention is definitely better than cure. And if you could prevent a cancer, the cost and the not just the economic but the physical burden of the disease is so much more. When you see a patient go through cancer treatment, it's like, it's not just the physical, it's the emotional.
Yeah, I know firsthand.
You know, right?
I know firsthand, unfortunately.
So that's why if we can prevent it, then nothing's more valuable than that. Yeah.
Speaking of like contributions and how you're saying that the 365 cancer cancer
Prevention Society.
the 365 Cancer Prevention Society, those people are volunteers, but I guess how about people, the everyday people, who maybe don't have time to go and do all this volunteer work? How do they contribute to something like that?
I think we are all sources of information for
Yeah.
one, because for every one of us, usually we will know either a friend or a relative, and nowadays with media being so powerful a tool, it's easily, you could just share a link, you could just tell your friends, you could tell your parents, basically spread the message to your loved ones. It's a very simple thing. So once you do that, inevitably, or rather, it would definitely be good when someone who is in that group or who needs a scope will then think twice about it. And then hopefully a percentage of them will come forward, and that will definitely benefit them. I think other than that, you taking care of yourself is also very important, right? So if they know all this information, they know how to keep in good shape, I think that's very in line what government is doing.
Yeah.
We talk about healthier SG, right? So prevention also starts with not just about getting people to get screened, but encouraging one another to go on good diet, live active lifestyle.
Yeah.
I think that's going to be
Stop your fast food.
that's going to be
Stop.
very
That's the hardest.
that's going to be very helpful though.
This
Yeah.
guy lived beside
Okay, we're not
McDonald's.
mentioning like fast food centers again, right? But yeah,
But for me,
yeah,
I
it's
know-
tough for me also. Don't worry.
Honestly,
Yeah.
I never thought that I probably might change, after this
Yeah.
conversation, because my meals consist of just really unhealthy food plus no vegetables. So
in a
that
way-
must change today.
In a way, that's why other people may feel that that's unfair too. Look at me, you eat all that, I don't eat that, and I'm still fat.
No, I tell you I eat only that, but I also didn't tell you how much I eat, so I don't have much money to eat, lah. That's why I'm very skinny.
Right.
Yeah.
Right.
Yeah.
Okay.
So
Okay.
lunch on you later, lah.
Dinner.
Dinner.
Supper.
Oh, lunch and dinner. Wow, you're so generous. Yeah, that's the last thing you need to do. Grab the Milo and 打广告. All right, ladies and gentlemen, fortunately or unfortunately, we have come to the end. Thank you, Doctor.
Thank you so
so
much.
much for
Nice.
being on our podcast.
Okay.
We'll definitely look forward to seeing you again.
Okay, sure.
Not in your clinic, hopefully. Hopefully here in front of the camera.
Okay, thank you so much for inviting me, and hope you all have a good evening too.
Yeah, great
Okay.
insights. See you soon.
Bye.